Good afternoon, my name is Meike Hirdes. I'm a PhD student at the Department of Gastroenterology and Hepatology at the University Medical Center of Utrecht in the Netherlands. Today I would like to show you that endoscopic placement of clip-assisted nasolateral feeding tubes reduces the number of repeat endoscopies for tube repositioning. In our endoscopy unit, despite extensive experience with feeding tube placements over a guide wire using transnasal endoscopy, we were frequently faced with feeding tubes that were placed in the stomach instead of in the duodenum. We also noticed that correctly placed feeding tubes often spontaneously seem to migrate back into the stomach. The aim of our study was therefore to evaluate endoscopic clipping of a nasoenteral feeding tube as a solution for both spontaneous retrograde tube migration and for incorrect placement of feeding tubes. We conducted a randomized controlled trial comparing clip-assisted versus standard endoscopic placement of feeding tubes. We included all clinical patients who were referred to us for endoscopic nasoenteral feeding tube placement, including those admitted to the ICU. We randomized patients between standard feeding tube placement using ultra-thin transnasal endoscopy over a guide wire versus endoscopic clip-assisted feeding tube placement. For the clip-assisted technique, we attached a suture to the distal tip of the feeding tube, and we then introduced the tube manually into the stomach. We then introduced the clip application device through the accessory channel and used this to pick up the feeding tube. The endoscope was then advanced as far as possible through the pylorus into the duodenum and clipped to the duodenal mucosa. The correct location of the feeding tube was verified with a plain abdominal X-ray within 3 hours after endoscopy. After the tube feeding was started, we followed each patient closely in order to early detect spontaneous retrograde migration, and in case of clinical suspicion of tube migration, we again made a plain abdominal X-ray. In total, we included 144 patients, 72 in each arm. Baseline characteristics were comparable between the two groups regarding sex, age, indication for tube feeding, location of admission, WHO score, and use of medication. Our primary study endpoint was repeat endoscopy for both incorrectly placed feeding tubes and spontaneously migrated feeding tubes. Clip-assisted feeding tube placement significantly reduced the repeat endoscopy rate, which was 28% in the standard group and 6% in the clip-assisted group. When looking closer at the repeat endoscopy rate, we saw that this could mainly be explained by the reduced number of incorrectly placed feeding tubes, which was 25% in the standard group and 4% in the clip-assisted group. When feeding tubes were adequately placed, spontaneous retrograde migration rarely occurred, with 3% in the standard group versus 1% in the clip-assisted group. There were no significant differences regarding complications related to the endoscopic procedures between both study arms. However, when looking at the procedure time, we saw that clip-assisted feeding tube placement was slightly more time-consuming than the standard tube placement, with 15 minutes for the clip-assisted tube placement versus 12 for the standard tube placement. And we also saw that the procedure was considered slightly more difficult by the performing endoscopist. In addition, we also calculated costs for both procedures, including the number of repeat endoscopies performed and the number of clips placed. We saw that the clip-assisted feeding tube placement was significantly more expensive than the standard tube placement, mostly because of the costs of the clip. Therefore, ladies and gentlemen, I would like to conclude that endoscopic clip-assisted feeding tube placement reduces repeat endoscopy rate, mostly due to a reduction of incorrectly placed feeding tubes. In addition, spontaneous retrograde migration rarely occurs after both clip-assisted and standard endoscopic feeding tube placement. However, due to the high cost price of endoclips, placement of a clip-assisted endoscopic feeding tube is still more expensive.